Definition of anxiety. Anxiety may be defined as a mood state characterized by worry, apprehension and physical symptoms. Symptoms of anxiety. Anxiety involves both physical and mental responses, manifesting as physical and psychological symptoms. Physical symptoms include dizziness, feeling lightheaded, sensation of shortness of breath, palpitations, sweating, trembling or shaking, feelings of choking, chest discomfort, nausea or abdominal distress, paresthesia. Psychological symptoms include feeling tensed and nervous, worrying thoughts, insomnia, irritability, poor concentration and memory, tiredness, restlessness, sexual dysfunction. Patient assessment. When faced with a patient with symptoms of anxiety, how do we differentiate normal anxiety from an anxiety disorder? The following provide an approach. Is what the patient experiencing pathological? What is the pattern of the symptoms described? What are the present stresses and problems faced by the patient? What can I do practically for the patient? Is a psychiatric referral necessary? Is what the patient experiencing pathological? Anxiety becomes a disorder when it is out of proportion to the danger or threat causing it. It continues even when the danger or stimulus is no longer present. It results in significant distress and impairment in social, academic, occupational or other important areas of functioning. It leads to avoidant behavior. It is important to exclude other conditions, both medical and psychiatric, which have associated anxiety symptoms. Medical conditions and medications associated with anxiety. Endocrine. Hypothyroidism. Hyperglycemia. Adrenal insufficiency. Hyperadrenocorticism. Phochromocytoma. Cardiovascular. Congestive heart failure. Pulmonary embolism. Arrhythmia. Mitral valve prolapse. Respiratory. Asthma. Chronic obstructive lung disease. Pneumonia. Gastrointestinal. Irritable bowel syndrome. Peptic ulcer. Hematological. Iron deficiency. Vitamin B12 deficiency. Neurological. Vestibular dysfunction. Migraine. Neoplasm. Epilepsy. Medications. Specific SSRIs are associated with an increase in anxiety in the first 2 weeks. Excessive stimulant, including caffeine and nicotine intake. Alcohol or drug withdrawal. What is the pattern of the symptoms described? The pattern of symptoms often gives a clue to the type of anxiety disorder the patient may have. Panic disorder. Recurrent unexpected panic attacks, in the absence of triggers. Persistent concern or worry about panic attacks or maladaptive behavior change. Agoraphobia. Marked, unreasonable fear or anxiety about 2 or more of the following 5 situations. Using public transportation. Being in open spaces. Being in enclosed spaces. Standing in line or being in a crowd. Being outside of the home alone. Also has active avoidance of feared situation due to thoughts that escape might be difficult or help unavailable if panic-like symptoms occur. Specific phobia. Marked, unreasonable fear or anxiety about a specific object or situation, which is actively avoided, for example, flying, heights, animals, receiving an injection, seeing blood. Social anxiety disorder. Marked, excessive or unrealistic fear or anxiety about social situations in which there is possible exposure to scrutiny by others. Active avoidance of feared situation. Generalized anxiety disorder. Excessive, difficult to control anxiety and worry about multiple events or activities. Accompanied by symptoms such as restlessness or feeling on edge, easily fatigued, difficulty concentrating, irritability, muscle tension, sleep disturbance. What are the present stresses and problems faced by the patient? One question that comes to mind when dealing with any psychiatric disorder should be why now? Patients usually present to us when their stresses go beyond their normal ability to cope. When this happens, we need to understand the changes in the person's environment that have caused the decompensation. While it is important to make the correct diagnosis so as to be able to prescribe the correct medical treatment, knowing the current stresses allows us to help the patient holistically and provide resources to the patient to help deal with the underlying issues. What can I do practically for the patient? Psychological therapy. Psychological treatment for an anxious patient may be in the form of simple interventions that can be employed easily even in a busy clinic setting. Therapeutic alliance. The establishment of a therapeutic relationship is key. This therapeutic alliance is vital to the process of emotional and psychological healing and sets the foundation for all subsequent interventions. The family physician is well placed to do this as he has obtained the trust of the patient and his family through years of collaborative interaction. Psychoeducation. For a patient suffering from an anxiety disorder, an understanding of the underlying disorder can by itself be therapeutic. Patients are instantly reassured just by knowing, from you, that they have a recognizable and treatable condition. Much can be achieved by just helping patients understand the nature and origin of their symptoms. Panic disorders are a good example where psychoeducation about the illness can be very useful. For example, in panic disorder, patients frequently think that their symptoms actually herald a heart attack. By educating the patient about the symptoms of a panic attack, the patient will be less fearful when an attack is imminent, thus alleviating the likelihood of triggering the crescendo of anxiety symptoms that follow. Teaching relaxation skills and stress reduction strategies. Stress reduction strategies, for example, deal with negative thoughts, diaphragmatic breathing, progressive muscle relaxation. Encourage to exercise more. Reduce alcohol and caffeine intake. Stop smoking. Involve family members. Utilize community or social resources. Supportive counseling. Cognitive behavioral therapy. Pharmacological therapy. The mainstay of pharmacological treatment for anxiety are the antidepressants. These are effective in both anxiety disorders as well as in depression. In terms of efficacy, all the various antidepressants are about equal or close to equal at about 60 to 70% of patients. They vary in their side effect profiles. All antidepressants also take on the average 2 to 4 weeks to take effect, and this should be explained to patient at the outset. Antidepressants have 4 advantages. Minimal addictive potential. No tolerance effects. Have anti-anxiety effects even in the absence of depression. And have minimal withdrawal symptoms. Pharmacological agents for treatment of anxiety and related disorders. Selective serotonin reuptake inhibitors. These medications are the first-line pharmacological agents used to treat anxiety disorders. They work by preventing the reuptake of serotonin by the presynaptic nerve, thus maintaining higher levels of serotonin in the synapse. There is a paradoxical increase in anxiety levels during the first 2 weeks of starting treatment. The anxiolytic effect occurs after 2 to 4 weeks. Examples of SSRIs are escitalopram, fluoxetine, fluvoxamine, paroxetine, and sertraline. Serotonin-noradrenaline reuptake inhibitors. These inhibit the reuptake of serotonin and noradrenaline into the presynaptic nerve endings. They have faster onset of action than the SSRIs and little interaction with other drugs. One example is venlafaxine. Noradrenergic-specific serotonergic antidepressant. The only example in this class is mirtazapine. Its sedative effect is advantageous in patients with insomnia. It also increases appetite and leads to weight gain. Tricyclic antidepressants. These are also effective for anxiety disorders. They have unpleasant anticholinergic side effects. Fatal arrhythmias occur with overdose. Antihistamine with anxiolytic properties. One example is hydroxyzine. Benzodiazepines. These are effective in reducing anxiety symptoms of GAD, panic disorder and phobias. Rapid onset of action. Biggest drawback is that chronic use is associated with significant potential problems including tolerance, dependence, withdrawal, relapse, rebound, interactions with other medications and adverse events. The patient should also be advised from the onset that this is not the definitive treatment for the anxiety disorder, and it is only meant to provide symptom relief while awaiting the antidepressant to take effect. Hence, benzodiazepines should be restricted to short-term use of up to 2 weeks when initiating treatment, and should not be used as monotherapy. They should be given at the lowest possible dose and gradually tapered off because of its addictive potential. They are contraindicated in those with alcohol or substance abuse. Commonly used examples are alprazolam, clonazepam, diazepam, and lorazepam. Pharmacological treatment pointers in anxiety disorders. Start with an SSRI. An adequate dose should be used, adequate duration is 8 to 12 months. It is okay to prescribe benzodiazepines, but watch for abuse or dependency. It is for use in the short term of 2 to 4 weeks only. Listen actively and give simple problem-solving advice. Encourage relaxation, stress reduction. Review regularly. Weekly to bi-weekly for first 2 to 3 sessions and monthly to bi-monthly subsequently. Is a psychiatric referral necessary? Most patients with anxiety disorders such as GAD and panic disorder can be managed in a general practice setting. Patients should be referred when symptoms are severe or complex. Symptoms fail to improve with initial treatment and follow-up. Co-occurring drug or alcohol abuse. There are psychotic symptoms. There is serious risk of suicide. Learning points. Anxiety disorders are common mental health disorders but are underdiagnosed and undertreated. Most cases of anxiety disorders are presented first to the primary care physician and can be managed in primary care. Take a good history of patient's symptoms, severity, duration, presence of psychosocial stressors, medical problems, and also assess suicidality. A combined approach of psychoeducation, relaxation training and medications give the best results. SSRIs are first-line pharmacologic treatment for most anxiety disorders. It is important to note that benzodiazepines has no role for long-term treatment. Treatment for generalized anxiety disorder should be for at least 32 weeks as high relapse rates are reported after discontinuing medications.
Audio Jungle. Audio Jungle.